Hello, everybody. I have the great honor to start this session with my co-chair, Professor Angeli, uh, and of course, Professor Tusulis. I would like, first of all, to express my gratitude for the honorable and the valuable, let's say, prize. It's a prize for me to be here. I feel really blessed. I would like to express my gratitude to Professor Sofia Mavrogeni for the kind invitation. And with no further ado, I would like to introduce the first speaker. It's our beloved Dr. and Professor Pepe. She's a radiologist and cardiologist, associate professor and coordinator deputy director in the Institute of Radiology at University of Padua, Italy. She's going, again to introduce us to the wonderful world of beta thalassemia. Professor Pepe has a very, let's say, interest in this kind of disease, and she has already published a lot of papers on this topic. So, Dr. Pepe, we are going, let's say, to follow an excellent, as always, presentation, and let's start as fast as possible, please.
Thanks for your kind presentation. I would like to thank my friend Sofia Mavrogeni for her huge work in order to connect all of us in this field. So I move to the presentation. Why CMR in thalassemia? As you can see here from this data coming from the Italian network, thalassemia, heart failure remains the main cause of mortality in thalassemia patients, also in Italy, where the patients are well treated and well chelated. We know that thalassemia is endemic in a black belt from the Mediterranean area to the Southeast Asia, but due to immigration, hemoglobinopathies are an health problem all over the world. During this year, we have worked really well on the heart. In fact, as you can see here, only 10% of our patients in Italy show heart iron. Conversely, about 50% of our patients has hepatic iron, and 19% of our patients show pancreatic iron. This was a really bad surprise. Based on our data, about 20% of our patients continues to suffer from heart failure. Traditionally, iron overload cardiomyopathy is considered a restrictive cardiomyopathy, so large atrial, small ventricle, preserved left ejection fraction with a restrictive left ventricle filling. But I think it's our common experience that thalassemia patients suffer from a dilated phenotype with a left ventricle remodeling, and along the time a possible reduction of the global systolic function, because probably the effect of anemia is stronger than the effect of iron. In fact, in the last European guideline, hemochromatosis are under the umbrella of dilated phenotype. when we started with the MRI at the beginning of our century, the clinical scenario was extremely stimulating because we started to use 2 oral chelators in monotherapy or in combination with subcutaneous desferrioxamine. We knew that cardiomyopathy was treatable and reversible if an intensive chelation treatment was instituted in time. But when we started, we didn't have the instrument in order to quantify iron. We knew that there wasn't a correlation between heart iron and the liver iron. As you can see here, we have a severe heart iron with a black myocardium and no iron in the liver. In other case, we can have a severe liver iron burden and no iron in the heart. Moreover, in the single patient, we don't have a correlation between serum ferrity and heart iron. Cardiac symptoms and signs arrives late because, for example, dyspnea is an aspecific symptoms in this anemic population. Traditional parameters of echocardiography arrive late, and cardiobiopsy is not present in the real clinical world because is an invasive technique, and moreover it shows a low sensitivity because iron is distributed in a patchy manner and is more present in the epicardial layers. It's funny that in the last guidelines endomyocardial biopsy is considered as a possible technique in order to quantify iron with a class indication of second A. Anyway, thanks to MRI, I think it's a common experience that we don't use biopsy. T2 star MRI was the first mapping in our clinical practice, so we can measure the signal intensity in our images. We know the TE values, so if we resolve this equation about T2 star, we have a number that can quantify iron. Iron is a super paramagnetic substance, so if we have iron, the signal decay faster in image weighted on T2 star, T1 and T2. So more iron and more faster decay, as you can see here. We can quantify iron only in the mid-ventricular septum, but I strongly suggest a multi-slice, multi-segment approach because iron is distributed in heterogeneous manner. And we can follow this approach today also using T1 mapping. And why to use a multi-segment approach? Because iron is distributed in a heterogeneous way. As you can see here, this is an anemic patient where we have iron in the lateral wall, but we don't have iron in the septum. So it's strongly recommended to measure iron by segmental approach. The technique has been calibrated against human hearts, and this study confirmed that iron is more present in the epicardial layer, but this study were important because they confirm that 20 milliseconds is a really conservative cutoff. At 20 milliseconds, we have iron in the heart of our patients. And if we want a totally iron-free patient, we have to move to 40 milliseconds. Nowadays, T2 star technique is available in a lot of MRI labs, but I would like to give some instruction for use. It's a quantitative technique. So in order to give good numbers, we need to test our normal cutoff value. So I always suggest to verify the cutoff value on at least 20 healthy subjects. And if the cutoff value of 20 milliseconds is not confirmed in healthy subjects, I suggest to check if there's a problem in our scanner, in the homogeneity of our field, magnetic field. Then the second phase, when we started with this quantification, is to check the transferability of the technique, asking to at least 5 patients to repeat the exam in their local center and a reference center. After this validation, the center is ready to quantify iron, but it's important to have skilled operators. I strongly recommended a cardioradiologist expert in hemoglobinopathy, having an imaging experience, and no an imaging specialist having an iron experience. So it's important training and accreditation, and during this days, thanks to Sofia, we are here for this. Thanks to MRI, our patients has improved their compliance because they could touch iron in their hearts, and as you can see here, the compliance showed after the first MRI scan a significant improvement, and thanks to MRI, the chelation therapy was tailored on each patient. 70% of the patients changed chelation therapy based on CMRI reports. And when we have to do our first evaluation in this patient, my suggestion is as soon as possible. These are data in our little patient, less than 10 years of age, and it's impressive that 11% of these patients were treated well chelated, apparently had iron in their hearts, and 73% of these little patients showed an heterogeneous iron distribution, also with a normal global heart T2 star value. So first MRI as soon as possible, when we can do this without sedation. After this, we have to repeat T2 star CMRI in mean every years, but if we don't have iron in the heart, we can do a follow-up every 2 years. Conversely, if we have red flag as an homogeneous and severe iron distribution, a reduction in the global systolic function, poor compliance. We can repeat the scan every 6 months. Never before, because it's not so easy to remove iron from the heart, so we need at least 6 months in order to see some changes. Thanks to collaborative network among thalassemians and MRI centers, we were able to quantify cardiac iron by T2 star in a large number of thalassemia patients around Italy, and we tailor the chelation therapy based on the MRI reports. And after 10 years of follow-up, as you can see here, we had a significant reduction in the patients with myocardial iron burden. We had a significant reduction of heart failure, but this is the most important results. We had a significant reduction in heart failure mortality. And the patients that developed heart failure during the follow-up had an homogeneous iron distribution, had heart dysfunction at the first MRI, and had myocardial fibrosis. For this reason, I strongly suggest a multi-parametric approach, so not only iron with the T2 star, but also cardiac function. You can see here that we have a consistent percentage of patients with no iron in the heart, but heart dysfunction. And in our experience, we had about 20% of our patients with replacement fibrosis, and fibrosis in our population is the stronger prognosticator, because we can remove iron thanks to the chelators, but we cannot remove fibrosis. And moreover, this is my impression in Italy, these patients are under treat by a cardiological point of view. We have patients with dilatation, with replacement fibrosis, without cardioactive therapy, and the results is the heart failure during the follow-up. Obviously, iron is the main cause of cardiomyopathies in this population, but we have to keep in mind the other causes as anemia, myocarditis, ischemia. These patients are becoming older, so there's also an ischemic cardiomyopathies in these patients. Which is the future ongoing about MRI and thalassemia? I think mapping, not only T2 star mapping, but also T1 and T2. T1 seems to be a more sensitive technique in order to quantify iron. You can see here a lot of patients with a normal T2 star value and an abnormal T1 value. So T1 is more sensitive to probably to ferritin. And if we want a totally iron-free patient, so we have to use also T1. In our report, it's frequent to conclude borderline iron overload. With this sentence, we indicate patients with a normal T2 star in any segment, but an abnormal T1 value. And in this patient, probably we have to intensify the chelation. T1 is less specific for iron, because it's sensitive to iron, but is also sensitive to fibrosis. So if we have a fibrosis, we could have a higher T1 value due to fibrosis. And in some segments, we have a pathological T2 star value and abnormal T1 value for this reason. There's a correlation between an history of cardiac complication and T1 value. We are waiting for prospective data. The limit of T1 mapping technique is the intercenter reproducibility, as we know well. But if we follow the patients using the same scan, is a very sensitive technique. I also suggest to quantify extracellular volume, because extracellular volume is significantly higher in thalassemia patients. Patients with heart iron show significantly higher extracellular volume, and it seems correlated with an history of heart failure. We started to use also T1 mapping. I thought to use T2 mapping in order to quantify iron, but T2 mapping is not so sensitive for iron, as you can see here. For example, we have a patient with a pathological T2 star value and a normal T2 value or increased T2 value. Probably so T2 is more sensitive to edema, inflammation in this population, and the inflammation is stronger than the effect of inflammation is stronger than the effect of iron. But I suggest this parameter in this population because we can have edema in these patients. Last but not least suggestion is a one-stop shop approach. So not only heart, but also liver. Liver predicts body iron stores. Liver iron concentration predicts a risk of hepatic complication. And leak predicts also survival in this population. And we can quantify liver iron by MRI in a few minutes. But today I strongly suggest to quantify also pancreatic iron. These are our data, 90% of patients with pancreatic iron, and pancreatic iron is correlated to glucose metabolism. If you have no iron in the pancreas, you don't have glucose metabolism alteration. The negative predicted value is 100%. So take-home messages, T2 star T1 technique today are unique parameters in order to tailor the chelation therapy in this population. Keep in mind that cardiomyopathy in this population has a complex etiopathogenesis, so use a multi-parametric approach, T2 star, T1, T2, and extracellular volume. In this case, it's important to have the cutoff value of center specific, do the quantification of the cardiac function, and use the normal reference value for this anemic population. And after 10 years of age, use a contrast medium for in order to detach replacement fibrosis. And it's important one-stop approach, so not only heart but also liver and pancreas, and always it's important to work all together about rare disease. I would like to thank all my collaborators in Padua, and I hope to see all of you in our 1-week residential course in 2005 or 2006. Thank you for your attention.
Professor Pepe, thank you very much for the excellent presentation. I would like, before going through some questions we have, me and probably my co-chairs, to encourage all the participants, all the people that are watching live the session, colleagues, cardiologists, radiologists, to ask. There is a special box for questions, and we can address the question straightforward to the specialists that are ready to answer your questions. So feel free, and we would like to keep it interactive here. And I would like from you, let's say, to ask as many questions as you can. Now, for the moment, I don't have any question from the audience, but I would like to ask you something that a little bit puzzled me. With echocardiography, we use most of the time and more the global longitudinal strain. There are some studies about beta thalassemia the last year that have concluded that the both global and regional circumferential and radial strain can be prognostic markers in people with beta thalassemia. I didn't have, let's say, the chance to see or to, go through why the global and the circumferential strain are better from the longitudinal strain in these cases. Do you have any explanation? Do you have any further comment on these studies? Do you feel that the global and the radial strain can give us some more prognostic information in these cases?
Okay, the data are non about strain. This is my impression, are going in different direction. For example, about MRI, okay, we have a strain, but in MRI, strain is not so useful because we can see the tissue. So the alteration in the tissue comes before than the alteration with the strain. And so in MRI, we give these parameters, but the tissue arrives before. In echo, it could be important because it could be a red flag in order to send the patients to MRI, because we know well that in some country it's not possible to send all the patients every year to the MRI. In Italy we can do it, but in other countries no. So we can use echo as a gatekeeper to echo strain, a gatekeeper to MRI. The problem are the cutoff value in this population. could be a problem. Why radial is a prognosticator and longitudinal is not a prognosticator? I don't have an explanation because the data are not so strong. This is my impression. The correlation is low, so we need more large multi-center data. I don't know which is your impression.
Yeah, I think that the limitation of all these studies, I mean, in beta thalassemia and CMR, despite the fact that CMR is probably the best imaging technique in order to identify, let's say, to characterize tissue, is the small number of patients with beta thalassemia. So probably we need to unite, let's say, efforts. I mean, to try, let's say, to have a protocol for all these cases in different centers, and have the same protocol, the same, let's say, project in order to identify this kind of differences in this population, which is not big. It's not, I mean, very big, and we need probably to have, let's say, to stick, let's say, together in special protocols, CMR protocols, in order to have this kind of information, which is valuable. And another question, and I would like my co-chair, Professor Angeli, if she needs to ask something, the speaker, our speaker, as far as we have a chance to have her with us. And the question is about the T2 star in liver. There are some studies suggesting that T2 star in liver is not reflective. It doesn't reflect the same value T2 star in the heart. So, do you think that this kind of infiltration of iron is the same in liver and the same in heart, or there are differences between these two organs?
Okay, the infiltration of the infiltration for the liver, the problem a problem today is a fat infiltration, because in these patients we have T2 star in the liver is sensitive also to fat, and these patients are becoming older. So are diabetic with cardiovascular risk factor. So we could have fat, and in this case we have to correct the T2 star value for fat infiltration, because we could have an underestimation if we don't do this. Thanks for your question, because this is we are discussing about art, but in this setting it's important to have one-stop approach, and so it's important to discuss about this limitation.
I think Sophie has a very, let's say, burning question.
Yes, I have a comment. First of all, congratulations, Alessia. It was a great talk as always, and we learn a lot from you and from the collaboration with you and all your experience. I just want to make a couple of things more clear for people who are not familiar with thalassemia. First of all, when somebody is exposed to iron, is the liver that suffers, because liver is the biochemical factory of the body in a simple way. We see very often iron only in liver, and the heart is intact. However, in the majority of cases, we see involvement of both organs, but always liver is in worst situation just because it's the first front against iron, and then heart is overloaded. And we also have cases with pure iron overload in the heart without iron overload in the liver. So it's important to understand this pathophysiology in order to be able to understand why we have this evolution of the disease. On the other side, whatever other tool we use, GLS strain or radial strain or whatever, it's an indirect way to think about the disease. The direct way is coming through the evaluation of the iron deposition. And CMR is the only modality that can give real information about iron deposition. Of course, if we don't have a magnet, we use the strain and everything. However, it will never be the gold standard because it's indirect. And don't forget that this strain is ST indices are evidence of a systolic dysfunction just before the ejection fraction, but not evidence of tissue involvement. Tissue involvement can be provided only by parametric imaging of CMR. And I think this will make clear the whole topic.
So about strain, I perfectly agree with you. In MRI, we have the tissue, so it's funny to use a strain. Moreover, there's a cost in order to analyze a strain because I don't know which software you use. You have to pay in order to quantify and to use a strain.
That's true.
So about the case with iron in the heart and no iron in the liver, probably this is the effect of the chelation therapy, because we can remove iron from the liver very fast, really faster. And probably we do a photo in this moment where liver is clean and I don't know.
And last idea came very early when we didn't have a specific treatment for heart iron. Now we have dedicated treatment to remove iron from the heart. So we can't find these images. But I just mentioned because it is in the literature.
Yeah, it's important. And I don't know which is your experience, but now we have a lot of patients with only T1 mapping positive, so iron in the liver and iron in the heart based on T1 mapping.
Because it's an earlier index, much earlier.
Yeah.
According to work of Moon very years ago, but it's a much earlier index.
Yeah.
May I do a comment?
Yeah.
Congratulations, Professor Pepe. Excellent and very comprehensive talk. I think that we need not only the iron deposition on the myocardium, but also the functional data of the myocardium, of the left ventricle and the right ventricle also. And we need also functional data of the right or left atrium also, the strain of atrium. So we need to collaborate both two techniques, echo imaging technique and MRI technique. And in everyday clinical practice, we need to use all this data. I would like to do a question, please. How often do you use T1 mapping in following these patients? So far, we need just T2 star in our department, but we're going to start to use T1 or T2 methodology. How often do you use?
We use always. Because because we have both T1, T2 and T2 star, and when we started to use all free mapping, we did this for research. But today, I think we have to do in our clinical practice, because we have a lot of patients with a normal T2 star value and low T1 mapping. And if the hematologist can increase the chelation therapy, it's important to do this. we don't have strong data about prognosis during the time, but I'm confident that also T1 is a prognosticator in this population. So today we want a totally iron-free patients. So if we have an indicator of iron, we have to use this.
I think we also need it for the calculation of ECV. So irrespective of iron quantification, we need it because now people with thalassemia don't die mainly because of iron, just because we have target treatment for the heart, but they die from fibrosis, for cardiomyopathy due to fibrosis. So we need definitely all the information, and you can't calculate ECV without native T1 and post-contrast T1. Obligatory, we do it. It's part of the study. It's part of the routine. And according to CMR recommendation, parametric imaging is part of the routine examination using CMR. They don't use it, only people who are not familiar with this and who do not like to learn more about the modality. The things have an evolution, so we have to follow the current evolution. That's it. And on the other side, I have to mention that strain rate evaluation by echo has a good correlation with the strain evaluation by CMR. So if you perform a CMR study, you can calculate everything. Strain in the atrium, strain in the heart, in right and left, and everything. If you have the relevant software, of course. However, both modalities have equal, excellent correlation between them regarding strain.
Okay. And
so in one examination, you can get strain, ejection fraction, wall motion, replacement fibrosis, diffuse fibrosis, inflammation, almost everything. I mean, your life will become. Of course, you can't perform MRI every day, and this is the role of echo. And this is the role of strain, I think, in the everyday evaluation, because whatever the patient feels will come for an echo. So if you have good CMR information at baseline and you perform serial evaluation of all echo parameters, and this is the complementary role.
Okay, on co-chair Dr. Daliani's comment on circumferential versus longitudinal strain, I think that we need more data, not only on thalassemic patients, in other group of patients. It seems that the circumferential strain is better than longitudinal. It's more, it gives more prognostic data. So I think that soon we have the opportunity to use 3D echo in every day clinical practice, so we have more accurate measurements, not only on longitudinal, but furthermore on circumferential strain. And this is the point. I think that in several group of patients, circumferential strain is better. It gives better information on systolic and diastolic function of the heart globally.
Yeah, I think that Professor Angeli is an excellent, let's say, consultant professor in imaging. He's very dedicated, let's say, all these years, and I think she can share some of her experience about the types of strain. To be honest, I have a little bit, I'm a little bit puzzled with circumferential strain because it's not reproducible sometimes in the ultrasound, and we need some data both for, echocardiography, for probably three-dimensional echocardiography and cardiac MRI about the reproducibility, the inter and intra-observer variability. And I mean, we need some more time, I think, in order, let's say, to have all this data available and go for it and move on.
We need more.
So I think that the next speaker is ready.
Practice, as you told.
Yeah.
We need more
Professor
practice.
Angeli, I think next speaker is ready, and we can move to his presentation. Thank you very much, Professor Pepe. It was excellent to have you with us. Let's hope next year, it's going to be more exciting, the whole field.
Oh, I think it's time for Greece to start performing again CMR in thalassemia in a more intensive way.
Yeah.
and compare with echo. So this is time now.
Yeah, I agree.
Yeah.
And so to all of you.